Good afternoon. Thank you everyone for joining today's infection control and antimicrobial resistance webinar hosted by the Communicable Disease Service. My name is Tara Fulton. I am a healthcare associated infections and antimicrobial resistance epidemiologist at the New Jersey Department of Health. As a refresher, these quarterly webinars alternate between topics related to infection control and antimicrobial resistance. Jason Mayer, our HAI coordinator, hosted the last webinar in September, which was focused on drug diversion and infection control. Today, we're really excited to present an antimicrobial resistance focused webinar on containing novel and targeted MDROs. Dr. Alyssa McMillan will provide an overview of some antimicrobial resistance surveillance testing that is available at the New Jersey Department of Health. Apologize. Having a hard time advancing the slides. Oh, never mind. Got it. Sorry about that. Yeah, Dr. McMillan will be talking about available testing for some novel and targeted MDROs, for example, carbapenem-resistant Acinetobacter baumannii and Candida auris, as well as other difficult to treat organisms. From there, I'm going to dive a little deeper into Candida auris and provide an update on current epidemiology, identification, and control strategies. So real quick, I want to go over some housekeeping. So you'll be muted for the duration of the webinar. If you have any questions, you can type them into the chat box, which we'll be monitoring as the webinar is progressing. We'll have some time to answer those questions at the end of the webinar, but if we can't get to your questions, don't worry. We'll have them written down and we'll be following up individually. I also want to let you all know that the webinar is being recorded and will be archived on our website. So we have everyone's registration information so we can send out these slides and distribute those in PDF form. So we don't have a date yet for the next quarterly webinar, which will be in winter 2020, but we do know it's going to be infection prevention related, so stay tuned for more information. But before we get started, I also want to highlight an exciting opportunity going on tomorrow. The New Jersey Department of Health, Dr. Lifshitz, who is the medical director of the Infectious and Zoonotic Disease Program at the Communicable Disease Service, will be discussing significant consequences of all the use and misuse of antimicrobials, and we'll be reviewing some of the essential steps we all need to take to win the battle against antimicrobial resistance. Like I said, the webinar is tomorrow from 11 a.m. to 12 p.m. and you can register online using the link I posted here. Now, without further ado, I want to introduce today's guest speaker, Dr. Alyssa McMillan, who joined the New Jersey Department of Health's Public Health and Environmental Laboratory in 2013 as a postdoctoral CDC APHL Emerging Infectious Disease Research Fellow. She spent 2 years as the Newborn Screening Program's lead molecular biologist and now serves as the program manager for the department's microbiology laboratories. She received her PhD in cell and molecular biology with a focus in microbiology, virology, and parasitology from the Perelman School of Medicine at the University of Pennsylvania. So with that, I'm going to hand it over to Alyssa, who will be talking about public health surveillance testing that is available to detect novel and targeted MDROs here in New Jersey.
Thank you, Tara, and good afternoon, everybody. I'm really happy to have the opportunity to share some lab testing that's available at the Department of Health, but also really depends on our clinical lab partners. So particularly for those of you who work in the clinical lab, I'm happy that you're here. So this week actually marks World Antibiotic Awareness Week, so it's a good week to have this webinar. And CDC acknowledged this week by publishing a report with an extensive review of the state of antibiotic resistance in the United States. And that was published last week and is available on their website if you guys are interested. And in this report, they report that there's more than 2.8 million antibiotic resistant infections every year. And these infections lead to more than 35,000 deaths. Over the past 5 years, they've seen a steady increase in the number of infections, but they also have seen a significant decrease in the number of deaths. The report also categorized some of the most important antibiotic-resistant organisms, and they categorized these into different threat categories. And the most critical threats that I've listed here include some of the following organisms: carbapenem-resistant Acinetobacter, Candida auris, which Tara will be talking about later in this webinar, and carbapenem-resistant Enterobacteriaceae. And so the focus of this talk is actually going to be on carbapenem-resistant Enterobacteriaceae. So I thought it was good to point out that this is considered one of the most urgent threats by the CDC. If you aren't aware, Enterobacteriaceae cause about 30% of healthcare-associated infections. So that's a pretty significant contribution to HAIs. And clearly the spread of drug resistance in this category is a big threat. So today I'm going to describe some background of what carbapenems are, if you're not familiar, and how resistance may arise in bacteria. I'll then discuss how this resistance is affecting our state in particular, and some specific strategies that the Public Health Laboratory is using to detect and characterize this threat, and the relationship that's really required between our clinical labs and our epidemiologic partners. So in order to discuss carbapenem-resistant organisms, we need to have a little bit of an understanding about what carbapenems are. So carbapenem antibiotics are considered the antibiotic class that's currently available with the broadest spectrum of activity and the greatest potency against a huge range of both gram-negative and gram-positive pathogens. So these are really valuable tools in treating infections. They were derived in response to the growing issue of resistance to other antibiotics, including classic beta-lactams. And carbapenems are relatively stable in the presence of beta-lactamases. The first discovery of carbapenem agents was made in 1976, and the first carbapenem that was actually brought to market in the United States was in 1985 with the approval of imipenem. And several additional drugs have since been developed and approved, and there are a couple other carbapenems that are approved for use in other countries, but not currently FDA approved. So what are carbapenems used for? As I mentioned, they are resistant to classic beta-lactams. So they're effective against infections that are caused by extended spectrum beta-lactamase producing bacteria. So really they were developed to fight bacteria that was already resistant to other antibiotic classes. Carbapenems are effective against a number of different types of infections: Haemophilus influenzae, anaerobes, most Enterobacteriaceae, staph and streptococci, and Pseudomonas aeruginosa. They're really frequently used to treat multi-drug resistant hospital-acquired infections. And they're considered kind of a last resort drug of choice. So for every antibiotic, there's a mechanism for bacteria to become resistant to that agent. And carbapenems are much like other classes of drugs. And this can occur two different ways. So you can think about this either through bacteria going through mutational events to acquire resistance, or through gene acquisition via horizontal gene transfer. So I've kind of separated this into two different categories. You can think of the first category of mutational events as a constant survival of the fittest type evolutionary battle. Certain mutations that either alter proteins or protein expression within the bacterial cell might allow the bacteria that's harboring those mutations to resist the activity of the carbapenem and then become resistant. Some examples of this would be mutations that might alter the target of the drug, that might reduce the permeability of the membrane, that would prevent the drug from even entering the cell, or increasing protein transporters in the cell membrane to actually pump the drug out of the cell. So those are all considered mutation-based resistance mechanisms. The focus of this talk is going to be primarily about resistance that's mediated by the other class of resistance acquisition, which typically involves an acquisition of a gene that encodes for an enzyme called a carbapenemase. So what is a carbapenemase? And you might be able to tell from its name, it's a protein that enzymatically hydrolyzes carbapenems. So I've given you this cartoon that shows the antibiotic in green, and the enzyme is shown in pink, and basically the enzyme is binding to the antibiotic and breaking it down so that it can't act against the bacteria. So carbapenemases specifically hydrolyze carbapenems, so that class of antibiotics that I just discussed, but they also work broadly against most other beta-lactam antimicrobials. So if you have a carbapenemase producing organism, you're going to be resistant to most drug classes. Carbapenemases are grouped into families, and I'll introduce you here to the 5 most common that we think about. So Klebsiella pneumoniae carbapenemase, or KPC as it's often referred to, is the most common carbapenemase found in the United States and in New Jersey. This gene is found in many other species of bacteria, so even though it's called Klebsiella pneumoniae, it's a gene that can be shared across many other species. Mostly it's found in Enterobacteriaceae. KPC refers resistance to all beta-lactam agents. Like I mentioned, it does provide resistance to not just carbapenems. The next group is the NDM, or the New Delhi metallobeta-lactamases. Those were first detected in 2009, and they've had extremely rapid global spread. The OXA48 class of enzymes are usually seen as less efficient carbapenemases, but they're also commonly occurring with other beta-lactamases, which kind of amps up their strength. VIM and IMP are less commonly seen. They've had a relatively slow global spread. VIM is primarily found in Pseudomonas aeruginosa, and both VIM and IMP are genes that we don't typically see in New Jersey. So the focus of the rest of this talk is going to be about detecting and characterizing carbapenem-resistant Enterobacteriaceae. But I want to introduce you to another acronym as well, and that's CPCRE. So like I mentioned before, you can have a resistant organism that's acquired resistance through mutations, or acquired resistance through gene acquisition, and that gene is the gene that's encoding the carbapenemase. And these are really the organisms that we're most concerned about. So when I say CPCRE, these are carbapenem-resistant Enterobacteriaceae that are actually producing a carbapenemase through one of these 5 gene categories. So what do we see here in New Jersey? I showed some data here that was taken from a study published in 2017. The study was performed in 2013, and it looked at patients from 8 New York and New Jersey medical centers, and they examined these patients for rates of carbapenem-resistant Enterobacteriaceae bacteremia. And they actually showed that New York and New Jersey is an epicenter for KPC-producing CRE. It has one of the highest prevalences of CRE in the United States, and about 10% of Klebsiella pneumoniae bacteremia was shown to be carbapenem resistant. So this is a significant number of infections in this area. Of all of the CPCRE, about 90% was KPC producing. So those other 4 classes of carbapenemases were significantly less represented. This study was from 2013, but at that time, NDM was sporadic, and VIM, IMP, and OXA48 were rare. We do see an increase in NDM infections in the past year or 2, but still VIM, IMP, and OXA48 are still relatively uncommon. So you might be thinking, wow, these are really widespread. Am I at risk? And I have to say that there is a very particular group of people that are most at risk for infections with these organisms. Primarily, those are patients that are being treated in an acute and long-term healthcare setting. Frequently, these are patients that have compromised immune systems. They might be diagnosed with cancer or be a recent transplant patient. These are patients that are on ventilators, have catheters, have central lines, or chronic wounds, and obviously these are points of entry for these organisms. Frequently, patients are at higher risk when they have long-term antibiotic use. We see a lot of cases of CPCRE when there is a history of medical care abroad, since there are different types of organisms in hospitals in different countries. I do have to stress that these infections are very deadly. We're not specifically sure of the mortality rate, but it's thought to be between 30 and 70% fatal. And it's 2 to 3 times more likely to be fatal than if you have an infection with the same type of bacteria that's susceptible to carbapenems. So hopefully now you have a better understanding of how big of a threat this is. And the threat is posed to all of us and our healthcare system. So what can we do about it? To us, the most important thing that we can do is to prevent morbidity and mortality is actually just to prevent the infection itself. And the best way we can do that is to identify cases. And we think of cases as either patients that have colonization with this bacteria or an active infection. And essentially what we want to do is identify these cases as quickly as we can so that we can use the best infection control prevention techniques that we have to prevent spread of these bacteria. So how do we identify these cases? And as a laboratorian, I like to point to the lab. The CDC has supported this initiative by establishing the Antimicrobial Resistance Laboratory Network. It was established in 2016, and it specifically supports laboratory efforts to detect antibiotic-resistant organisms. It includes a huge team of CDC scientists and laboratorians, but it also serves to fund and train local, state, and regional public health departments to perform surveillance for antibiotic-resistant organisms. There are ARLN laboratories in all 50 states, 5 large cities, and in Puerto Rico. And although one of the primary focuses of the ARLN is carbapenem-resistant Enterobacteriaceae, there is also a lot of work done with other organisms, and I've listed some of those here. So if these are organisms that you're interested in having additional antibiotic resistance testing for, feel free to get in touch with us, and we can definitely connect you with an ARLN lab that performs that testing. So what kind of testing do we support here at the New Jersey Department of Health Lab? So we are a member of the ARLN, and one of our primary focuses is testing for carbapenem resistance. So I just want to walk through how our surveillance system works. The first step happens in the clinical lab, and that's kind of why I want to point out how important our clinical laboratory partners are. So the clinical lab will collect the sample from the patient, they'll isolate the bacteria, they'll identify what the species is, and then perform antibiotic susceptibility testing. And this is all really important to help treat the patient. However, if they have a suspected carbapenem-resistant Enterobacteriaceae or carbapenem-resistant Pseudomonas aeruginosa, we highly, we would love to get those isolates in our laboratory so we can help characterize them to a greater level and help perform additional surveillance. So our current clinical laboratory partners will send those suspected CRE or CRPA isolates to us. And once we receive them in our public health lab, we do a number of tests that both confirm some of the work that's done in the clinical laboratory, but also work to increase the characterization so we have a better understanding of what this organism is. So first we confirm the identification of the organism, that's to the species level. We also confirm susceptibility. So we will look at the susceptibility profiles that our clinical lab partners give us, but we'll also do additional testing on new organisms and also focus a lot on the carbapenem class of drugs. Once we confirm that they actually are carbapenem resistant, we'll do a phenotypic screen for carbapenemase production, and that's really important to help screen out those organisms that are producing that enzyme. Finally, if we find that it is carbapenemase producing, we'll do a qPCR assay to determine the molecular detection of the resistant determinants. And that's basically just to determine which of those 5 genes we spoke about earlier is actually producing the carbapenemase in that bacteria. So this is our current testing menu for our carbapenem-resistant Enterobacteriaceae and carbapenem-resistant Pseudomonas aeruginosa testing. So once we receive the isolates from our clinical lab partners, we do species ID either using a Vitek 2 or a Bruker MALDI-TOF method. We perform a very classic disk diffusion method to do susceptibility testing, and we use a number of different antibiotic disks, and I'll talk a little bit more about that, but we aren't looking at just carbapenems. We're trying to get a greater look at what the rate of resistance is across a greater number of classes of antibiotics. Our carbapenemase screening method is called the Modified Carbapenem Inactivation Method, or MSIM. I am not going to talk about it in great detail here, but please get in touch with me if you have additional questions about what that method is or how we perform that. Basically, what we're looking at is the bacteria producing a carbapenemase that can actually inactivate carbapenems. We're looking at that phenotypically. Once that screening method is complete, again, like I mentioned, we're doing a molecular detection for antibiotic-resistant determinants via real-time PCR. And again, we're looking specifically at those 5 genes that I spoke about earlier. So this is a list of the antibiotics that we're using. We are covering 5 different classes of drugs when we do our disk diffusion antibiotic susceptibility. And we have a slightly different list of antibiotics that we use depending on whether the organism is an Enterobacteriaceae or a Pseudomonas, just based on the natural resistance profiles of these organisms. And what we really aim to do is complement rather than duplicate efforts from clinical labs. We're trying to get a larger picture and complement the work that you have already done in the clinical lab. So what happens after that? So we've performed our laboratory testing, we have our results. What happens now? So a lot of things. The lab is really just a small part of the focus of the ARLN. Once the results are available, we send an email or a fax back to our clinical laboratory partner that submitted the sample. We also will let our epidemiology team here at Communicable Disease Service know about those results, particularly if they are showing something of interest, and I'll talk about that a little bit more. We send monthly reports to CDC so they can collate data from across the country. And we also will let them know if we have something, again, of an alert value. If we do have something that we need to follow up with, we work through our Communicable Disease Service to get in touch with the healthcare facility that might have housed this patient. And our epidemiology team will help mitigate potential downstream effects of having a patient with a highly resistant infection. Sometimes we send isolates to CDC if there's a particular interest, and we also have support from our regional laboratory at Wadsworth Center in New York State. And oftentimes these organisms get whole genome sequencing. So what are we really concerned about? CDC and ARLN have set some specific alert values, and this is just so that we can narrow down what is really highly consequential. So first, an organism that shows pan resistance, or that is resistant to every antibiotic that we've tested. We're also interested in possible novel resistance. So this would be seen if the organism is definitely expressing a carbapenemase that we see in our phenotypic screen, but is PCR negative for all 5 of the main genes. We're also really interested in non-KPC carbapenemase producing CREs. KPC is endemic, so if we followed up on every case, we wouldn't be able to sleep at night. And then we also follow up on CP-CRPA, since that is also very rare. There are other antibiotic-resistant laboratory services available. Most of these are provided by the New York Department of Health. I mentioned the Wadsworth Center is our regional support laboratory for the ARLN. So I just wanted to review some of those testing options that are available. And if you are interested, of course, get in touch with us and we can help mediate that testing. So they do Candida auris isolate characterization through both identification and antifungal susceptibility testing. They do perform Candida auris culture from a patient swab, and that would be for surveillance purposes. They also do carbapenemase producing Acinetobacter baumannii characterization, including whole genome sequencing. We have seen some outbreaks of A. baumannii in New Jersey, so we know that we've used these services before and really benefited from them. And finally, they offer expanded antimicrobial susceptibility testing for hard to treat infections. So these would be Enterobacteriaceae that are resistant to every antibiotic that a clinical lab is trying, including SGNM, avibactam. I'm sorry, the expanded susceptibility testing would include SGNM, avibactam. That's usually not available in a clinical laboratory. But Wadsworth Center has a novel assay to determine susceptibility to this drug combination. So if that's something that you might be interested in, again, just let us know. And with that, I will wrap up. I just want to say thank you to the ARLN team at our laboratory and also to our epidemiologists here at Communicable Disease Service, including Tara. And thank you for inviting me here to speak. And I'd be happy to answer any questions at the end of the talk after Tara's presentation. Thank you.
Thank you, Alyssa. That was a great presentation. So now I want to dive a little bit deeper into Candida auris and provide an update on the current epidemiology, identification, and control strategies. So you may have noticed that Candida auris has been making the headlines lately and is receiving a lot of media attention. Unfortunately, we're quite familiar with it here in New Jersey, where it's taken a strong hold, particularly in the north and central regions. So why are we concerned about this yeast, and why is it getting so much attention? Well, because it's a multi-drug resistant fungus that really truly distinguishes itself from other common Candida species. Its drug resistance is unprecedented among other known yeasts. Patients can become easily colonized and develop invasive infections, and it can cause outbreaks in healthcare settings to an extent that hasn't been seen with other Candida species. So C. auris was first identified in 2009 when it was isolated from a patient's ear in Japan. Auris is Latin for ear, hence the name. By the time it was identified in the United States in 2016, the organism had already been identified in 13 countries across 4 continents. If you fast forward 3 years later, we have invasive infections in 38 countries spanning every inhabited continent. So what's fascinating about the emergence of this fungus is that it appears that 4 distinct clades or types of fungi of this species emerged independently and simultaneously in 4 geographic regions. There's a real strong clonal population within East and South Asia, Africa, and South America. And whole genome sequencing has revealed that all 4 confirmed clades can be found here in the United States, suggesting that there have been multiple introductions from abroad. As you can see in this slide, New Jersey cases are related to isolates in South Asia. Now, the majority of cases in the US, however, don't have direct links to healthcare abroad, but are a result of introductions from abroad followed by local transmission. And as with most other multi-drug resistant organisms, the big travel hubs are seeing sporadic cases, whereas the Northeast first had importation, but is now seeing transmission within and across state lines. As you can see, New York, New Jersey, and Illinois, specifically Chicago, are carrying a lot of the weight due to local transmission. And very recently, Florida began reporting an increase in cases as well. So now, of course, a headline-making trait, and one of the most convincing concerns about C. auris is its drug resistance. And unlike antibiotics, there are only 3 major classes of antifungals in the United States, meaning that even small levels of antifungal resistance can severely impact the treatment options for an infection. Azoles are found to be rarely effective against C. auris, which is particularly important since azoles are an affordable antifungal treatment and often the only available option in many parts of the world. Our other 2 classes of antifungals, which are polines and echinocandins, are still somewhat effective, but if we're forced to use this drug more and more, there is an increased risk for more resistant Candida isolates. All in all, about 33% of isolates are resistant to at least 2 drug classes. Unfortunately, 2 C. auris isolates have been found to be pan-resistant, to all 3 classes, leaving no traditional treatment options. It appears that the cases which were identified in New York are not related and developed pan-resistance in response to treatment. Unfortunately, pan-resistance has been reported from a few other countries as well. So why else are we concerned about Candida auris? Well, because patients can become easily colonized and go on to develop serious invasive infections. So C. auris really affects the sickest of the sick. Patients are often ventilator dependent, have invasive medical devices such as breathing tubes and central venous catheters, have been hospitalized in healthcare facilities a long time, or are on broad spectrum antibiotics or antifungals. Additionally, stays in post-acute care facilities such as ventilator skilled nursing facilities and long-term acute care hospitals are a major risk factor for the acquisition and development of invasive infections. In fact, a recent study conducted by New York found that the prevalence of C. auris in ventilator skilled nursing facilities was around 8% versus less than 1% in regular nursing homes. And similar to other novel or targeted MDROs, receiving healthcare from abroad is another risk factor for C. auris. In fact, CDC recommends screening patients that reported healthcare exposures in countries where C. auris had been reported. At any point after becoming colonized with the organism, patients are at risk for developing infections. In some patients, the disease can enter the bloodstream and spread throughout the body, causing serious invasive infections. In addition to bloodstream infections, Candida auris has been found to cause urinary tract, wound, surgical site, and even bone infections. Since this yeast is often does not respond to commonly used antifungal drugs, infections are unfortunately very difficult to treat. So in addition to causing invasive infections, Candida auris colonization causes outbreaks in healthcare settings where many individuals with risk factors for colonization and infection reside. Unlike other Candida species, which are not usually associated with outbreaks, C. auris acts like a bacteria that can spread from person to person or through contact with contaminated environmental surfaces or equipment. As you can see, C. auris is found primarily on the skin, but other sites can become colonized, such as nares, respiratory tract, and ear canal. Unfortunately, there are no decolonization strategies at this time, and when patients become colonized, patients are often colonized indefinitely. CDC is not exactly sure of the timeline, but we do know that patients can be colonized for years and can show intermittent colonization. It's important to remember that colonized patients remain at risk for transmitting the bug, even when they're not actively infected. So one of the reasons C. auris is able to spread is because it's an extremely hardy bug that persists on surfaces. Environmental sampling has shown that C. auris can be found throughout the patient's environment, with bed rails or mattresses being the most common site, followed by windowsills and chairs and countertops. And what's scary about the organism is that it's been shown to remain viable on surfaces and medical equipment for months. So specific disinfectants and practices aren't used to clean these surfaces. The organism is easily transmitted. So when we think about the environmental disinfection, we're thinking about cleaning the patient's room, but we often forget about mobile equipment. However, studies have shown that mobile medical equipment such as blood pressure cuffs, thermometers, or pulsometers have been heavily implicated in transmission. In fact, a study that was conducted in New York illustrated that it's not just roommates that colonization is passed on to, but patients that overlapped and stayed on the same unit are also at risk. So if the bug is able to be carried around on mobile equipment, it can really set up shop. So we've talked a whole bunch about risk factors and epidemiology of Candida auris. Now I want to go into identification and some of its challenges. Because this is a newly emerging yeast, not a lot of yeast identification methods were able to identify it initially. When C. auris first appeared, the only methods that were able to correctly ID it was DNA sequencing and a molecular ID method called MALDI-TOF. Back in 2017, we did a lab survey to see what methods New Jersey clinical labs were using for yeast identification, and only about 25% of labs were able to correctly identify the emerging yeast. In fact, the majority of clinical labs were misidentifying the bug as a slew of other yeasts using common methods. This is a list of misidentifications by iLab ID method that CDC has on their website. As you can see, I highlighted Candida hemolonii because it's the most common organism that C. auris was being misidentified as. It's important for facilities to know what their lab uses and what possible misidentifications could be to be able to suspect C. auris. That being said, we are in much better shape now in terms of being able to correctly identify the yeast. This is mostly due to improved access to FDA-approved automated instruments that can detect C. auris. Of course, there is more awareness now, so people know to look for it. And finally, we have expanded ability to confirm suspect isolates at reference and public health labs, as Alyssa mentioned earlier. So another challenge with identifying the yeast is that in many labs, yeast is not determined to the species level except for by request, which is often only done for isolates collected from sterile sites. However, because the presence of C. auris at any site presents risk for transmission and infection, it's important to know the species of Candida in order to implement appropriate infection prevention and control measures. In the US, almost half of clinical cultures came from non-sterile sites, so we would have been missing those cases if species identification hadn't been conducted. So CDC currently recommends speciating all Candida isolates from sterile and invasive sites all the time. Speciating non-sterile sites may be challenging since it places considerable work on laboratories, and even worse, could lead to treatment of Candida in sites where it's not causing infection. However, given the emergence of C. auris, species-level identification should be considered even for non-invasive sites in certain situations. For example, if a case of C. auris is detected in a facility or unit, species-level identification from non-sterile sites may want to be considered for at least a month to rule out evidence of transmission. CDC also recommends speciating Candida isolates from patients that reported healthcare exposures in countries where C. auris had been reported, and of course, when clinically indicated or if a patient isn't responding to therapy. If speciation is not taking place, then facilities should be monitoring changes in the overall number of Candida species infections. So a challenge with identifying colonized patients is that they are asymptomatic and may have been colonized for months before the organism was detected, which of course means that the organism may have been silently spreading. Another challenge with detecting colonization is the availability of testing. While colonization screening is available through public health testing, commercial testing is not yet available. And until very recently, C. auris colonization testing was only done by specialized culture method, which had a long turnaround time. The good news is that PCR is now available through public health testing with a much quicker turnaround time. And also PCR is even better at picking up the organism. So I do want to mention that some healthcare facilities are using a direct plating method to conduct admission screening. Direct plating is basically streaking the contents of a swab onto a commercially available plate that helps identify the bug. I do want to mention that this method does miss at least 25% of positive C. auris specimens compared to the specific procedures conducted at public health labs. While the New Jersey Department of Health encourages facilities to conduct admission screening in-house, we strongly recommend that facilities reach out to us for testing support to screen high-risk contacts, for example, roommates or other patients that overlapped with the recently identified case, and of course, if transmission is suspected. Then that's because direct plating, like I said, misses about a quarter of those positive specimens. And while we wish we could support admission screening facilities, we have limited resources and capacity to do so. So all of the C. auris testing that our team supports is through CDC's antimicrobial resistance lab network. In addition to conducting surveillance testing for contacts or entire facilities when transmission is suspected, our team can support confirmation testing of suspect C. auris isolates. That is, if they fit into that table of misidentification I previously showed you. And all of these activities, including shipping, are covered by public health funding. So now I'd like to hone in on infection prevention and control efforts and highlight common opportunities for improvement that have been identified when working with healthcare facilities that are battling C. auris. So 3 particularly important strategies to combat C. auris are hand hygiene, the use of PPE, and environmental cleaning and disinfection. So as you can see, we're really focused on improving the basics. The number 1 way of breaking the chain of infection is hand hygiene, specifically with the use of alcohol-based hand rub. There is a time and a place for hand washing, for example, during outbreaks of infectious diarrhea, if hands are visibly soiled, and when caring for patients with certain organisms such as C. diff or norovirus. But for Candida auris, alcohol-based hand rub is the preferred and recommended method due to access and efficiency. So appropriate use of PPE is an area where most facilities find opportunities for improvement. When we think about PPE, we should be thinking standard in addition to transmission-based precautions, which entails contact droplet and airborne precautions. Just recently, CDC introduced enhanced barrier precautions, which is a set of precautions specific for nursing homes that fall between standard and contact. In nursing homes, there is an important balance between limiting the spread of C. auris and other MDROs and residents' quality of life. Nursing homes are also faced with physical space challenges and often do not have private rooms. That being said, enhanced barrier precautions was introduced to prevent the spread of MDROs while taking into account unique challenges in nursing home settings. It's a balanced approach that is more specific than standard precautions, but less restrictive than contact precautions, and is able to be sustained for a prolonged period of time. So in terms of the appropriate use of PPE for C. auris patients in different healthcare settings, the recommendation is that for patients that are colonized or infected with C. auris in acute care or long-term acute care hospitals should be placed on contact precautions in a single room with dedicated equipment. And for patients that are colonized or infected with C. auris in nursing homes, they should be placed on enhanced barrier precautions unless they have acute diarrhea, draining wounds, secretions or excretions that can't be contained, in which case they should be placed on contact precautions. Enhanced barrier precautions entail the use of gowns and gloves during high contact resident care activities, which were informed by nursing home specific research, assessing which resident care activities were highest risks for transmitting MDROs. A comprehensive list of activities can be found on CDC's website listed on this slide. And unlike contact precautions, patients on enhanced barrier precautions can leave their rooms as long as excretions and bodily fluids are contained and the resident can perform hand hygiene when appropriate, for example, when they leave their room. So again, I'm going to go through this again. For C. auris transmission-based precautions, it entails the use of contact precautions for all C. auris cases in acute and long-term acute care facilities, and for C. auris patients in nursing homes that have acute diarrhea, draining wounds, or secretions that can't be contained. If nursing home patients do not have diarrhea, draining wounds, or secretions that can't be contained, then the use of enhanced barrier precautions is appropriate. Now, in terms of environmental cleaning and disinfection, CDC recommends using EPA-registered hospital-grade disinfectant effective against C. auris or products that are effective against C. diff spores. And a facility may want to consider using these disinfectants throughout their facility if they're seeing multiple cases of C. auris. In addition to thorough environmental cleaning in patients' rooms and in areas outside of the room where they receive care, shared equipment needs to be cleaned daily with products against effective against C. auris, ensuring that appropriate contact times and dilutions are followed. Also, CDC recommends minimizing the number of folks caring for C. auris patients. For example, if multiple C. auris patients are present in a facility, staff should be cohorted for these patients to the extent possible. And when rounding, staff should prioritize their workflow. For example, starting with patients on standard precautions, then moving to transmission-based precautions rooms, and then C. auris rooms. And again, CDC recommends speciating all Candida isolates when facilities are caring for a C. auris patient to detect additional colonization. And finally, both verbal and written communication is critical to contain the spread of C. auris. When patients are transferred to other healthcare facilities, the receiving facility should receive notification of the patient's infection or colonization status, as well as recommended infection control precautions. At the Communicable Disease Service, we have developed communication tools and informational resources to combat C. auris and strengthen infection prevention across the continuum. We just recently updated our transfer form to reflect updated CDC recommendations, which can be found on our C. auris website. I encourage you to take a look at our website for additional tools. If C. auris transmission is suspected, we work with healthcare facilities to identify overlaps in location, equipment, and types of care for patients with C. auris to hone in on where infection control efforts should be intensified. We typically recommend routine surveillance through periodic point prevalence surveys until transmission is controlled. Additionally, our team may perform a consultative site visit to observe control measures and identify areas for improvement. And as you can see on this map, we're seeing the majority of our cases in the Northeast region, which of course neighbors New York, where the burden of C. auris is very high. This map depicts the number of cases identified in each county. I do want to note that while there are multiple facilities in the Northeast region experiencing transmission, that is not necessarily the case in other counties where facilities have reported cases. Also, since most of these patients are healthcare experienced or frequent flyers, it's important to remember that patients may have been exposed to the yeast in one facility and identified in a different facility. Of course, controlling the spread of C. auris is more difficult when the bug establishes itself in healthcare environments or transfer networks. So our containment approach is to conduct routine surveillance in facilities with documented transmission and aggressively follow up with targeted screening and patient traceback, especially when C. auris is identified in facilities outside of the established outbreak network. That being said, it's critical for healthcare facilities or laboratories that suspect that they have a patient that is either colonized or infected should contact the Communicable Disease Service or their local health department. Our team will work to ensure that C. auris specific infection prevention and control measures are put into place and help identify and screen high-risk contacts that may have been exposed to the organism. Of course, we're always here to answer questions, so don't hesitate to reach out. So with that, I'm going to wrap it up. But if anyone has questions, which I see a few questions have come in for either Alyssa or myself, please continue to type them into the chat box. So let's look here. So we'll be sending, the first question is the link for the stewardship webinar. We'll be sending out a copy of these slides, so be able to access that link. And the second question is we will be distributing the slides. The next one I think is for Alyssa.
So the next question is, as a resistance to ceftazidime avibactam emerges, will the New Jersey Public Health Lab be looking at other drug combinations? And right now we're following ARLN guidance on which antibiotics we're testing for our Enterobacteriaceae and Pseudomonas. So to date, ARLN has not recommended testing for these combinations. I will say though that if you have specific Enterobacteriaceae that you think might have pan resistance, we would be happy to see whether they meet the criteria for expanded AST that is available at our regional laboratory in New York. So currently we don't test for those, but we could set you up with testing if you are interested.
So I'm actually going to go back to, let's see here. Oops. Okay, so that is the webinar link for the stewardship webinar that's going on tomorrow. If you want to, I know it's a little bit long, but if you want to type it out, I'm going to go to the next questions with which is in skilled rehab patients with C. auris on sputum and urine, do we need to culture patients before discharging home? No, it's not a recommendation that we have at this time. The next question is this recorded? Yes, it's going to be recorded and put on our website. And for the MDROs that we can use enhanced barrier precautions for, there is a list of novel and targeted MDROs. If you go on CDC's website, basically you could just search enhanced barrier precautions in nursing homes, or even just enhanced barrier precautions, and it will take you right to the CDC's website that lists the organisms that it applies to. So the next question is tricky. How long patients should be on isolation when C. auris is confirmed? Well, right now, CDC, there isn't evidence showing that a patient can completely clear C. auris. So the recommendation is that they should be placed on contact precautions and pretty much indefinitely, and unless their health improves significantly. For example, like if they didn't even need to be in a healthcare facility setting anymore. So it's a tricky one, but for the information that we know of right now, that's the current recommendation. Primary signs and symptoms of C. auris for patient. So unfortunately, these individuals are very sick already, and there isn't necessarily signs and symptoms specific to C. auris. You know, if they have invasive infections, then those are some of the signs and symptoms you'd see for, you know, other organisms that are causing invasive infections as well. But there aren't specific Candida auris signs and symptoms. For patients in nursing home settings, would we use enhanced barrier precautions as well? I'm sorry, in home settings. There isn't enhanced barrier precautions. There's no recommendation specific for enhanced barrier precautions for the home setting. It would be, you know, if somebody is caring for a patient that they're exposed to the bodily fluids and, you know, other high risk activities, then they should be using, you know, appropriate PPE just to protect themselves. I'm going to come back. You can answer. Melissa's going to answer a specific lab question.
So the question is regarding the phenol test for identification for Candida auris. It seems like there are labs out there that believe that the phenol test would be, you know, acceptable to test for C. auris. We really like to see on the lab side, if a yeast is suspected, that a species confirmation be done with an FDA approved test. If you don't know, if you don't have an FDA approved test and that's not a possibility, I would definitely recommend trying to isolate it and sending that isolate to our regional lab, and Communicable Disease Service can help navigate that, and as well as the New Jersey Public Health Lab, if you need assistance in truly identifying it.
Any new recommendations for Candida auris screen culture is done by hospitals, particularly in regards to media, incubation, temperatures, etc. No, CDC doesn't have any different recommendations for hospitals. Like I said, the direct plating method is what a lot of hospitals are using, and there isn't really, CDC hasn't come up with any improved methods to detect C. auris using those methods. If the cultures are already negative and is not showing, do we need to continue to isolate? So patients have been found to be intermittently colonized with Candida auris. So while they may go on to have 3 negative cultures, months later, they may have another culture that is positive. So the recommendation is to continue to isolate. Another question is, when is a CRE patient eligible for screening? And that is similar also to when a Candida auris patient is eligible for screening, and that's really if the patient has has significantly improved and is basically not requiring any kind of health care to the extent where we see most of these patients. What can we do to prevent it? Well, I wish I had all the answers. Again, we closely follow and look at what CDC's recommendations are, and that's what we're always communicating out to our partners. That's everything. Their recommendations is based on the data that they're collecting, and we just keep following. One of the recommendations we do have is for early detection. So if you're maybe doing admission screening, or if you're working with us to make sure that if there's a patient that is identified in your facility, that we're looking for additional patients that may have been exposed to the organism. So as soon as we can find those patients, we can place them on the appropriate infection prevention and control measures so that the organism does not spread. Every day. Yes. UV lights, the question, I'm sorry, is UV lights good after bleach cleaning? And the UV lights should not be used in place of bleach cleaning or other cleaning with the products effective against C. auris.
All right, this is going to be the last question, and it had to do with the follow-up answer to a previous question about what lab test is recommended for C. auris instead of the phenol test. And I didn't have a specific test there. Tara did have a slide that had the FDA approved options that are currently available for C. auris testing, and really we recommend using one of those so that you can confirm the species.
So I think that's all we have time for today, but thank you everyone for joining today's webinar. We appreciate your time and attention, and stay tuned for more information on our Winter 2020 webinar.